Multifocality. So first we'll have Dr. Jayanthan, who's going to talk to us on multifocal glasses and contact lenses. He's a pediatric ophthalmologist and a refractive surgeon who's very well known in India. Yes, over to you, Jayanthan.
Uh, Thank you, Nishan. Thanks for including me in your instruction course. So basically, I'll cover the basic part of presbyopia correction, the glasses and the contact lenses. So when it comes to the correction of presbyopia, we are familiar with the single vision lenses, bifocals, and the progressive addition lenses. Single piece lenses that vary gradually in the surface curvature from the minimum value in the top portion to the maximum value in the lower near portion. It ensures the right dioptric power for every distance, guaranteeing a smooth, it gives a continuous range of vision and it's comfortable intermediate also. So basically the designs are mono and multi design. We have a asymmetric symmetric pattern and hard and soft designs. Mono design, a single design used for all addition powers, whether it is 1, 2 or 2.5. So the position of the near vision does not change with change in the near addition power. In a multi-design, a position for the near vision changes with addition of the power change, and the near area goes up with increase in addition. Coming to the symmetric and asymmetric, in a symmetric, we have the right and left lenses that are identical. Basically, the center point of the distance correspond to the center point of the near. What we need to do is we need to slightly rotate the lens. So by doing this, there will be a lot of distortion on the nasal part. So to overcome this, we came up with the asymmetrical progressive addition lenses, which incorporates a slight nasal offset of the near zone and has got a separate design for the right and left lenses. And the most recent advancement is the horizontal symmetric, where the astigmatic pattern is also actually decentered so that the patient doesn't have an extra distortion when they are reading. Hard and soft lenses. Harder design concentrate the astigmatic error, that is the blend zone, into a smaller area of lens surface, thereby expanding the area of perfectly clear vision, but at the expense of the level of a higher level of blur and distortion. So basically, the central reading part will be actually larger and the distortions will also be larger. So in a softer design, the reading part will be smaller, but the peripheral will also be blended, so the overall magnitude of blur is actually reduced in these softer designs. So the harder design is preferred if the patient is already previously using a hard lens and who do a lot of reading. Basically, when you're sitting and reading, it helps a lot because you can't move around because the blur is going to be larger in the harder design. For an young presbyope, active outdoor profession and professional drivers, the soft design is what has been preferred. So there are certain clinical markers when it comes to dispensing of progressive addition lenses. You need to adjust the angle of the temple so that the frame sits squarely on the face. This holds good when you are dispensing and if a patient is unhappy and coming back to you with the progressive lenses. Adjust the temple to achieve 8 to 12 degrees of tilt and make sure the contact with the cheek is avoided. The front of the frame should follow the line of face. The temple length should be adjusted so that it doesn't slide, because once it slides, then because of change in the vertex distance, there will be a reduction in the performance of the progressive addition lenses. Adjust the nose pad because minimizing the vertex distance will help the patient read better. Monocular PD fitting height has to be marked, so that's one advantage which I usually tell to the patient when they wanted to go for online shopping. Poor candidates, mostly patients who have got motion sickness, who are already much satisfied with bifocals, who require high addition ads, and vertical muscle imbalance, anisometropia, larger pupils are all poor candidates for a progressive addition lenses. So keep in mind that trying to choose a overall one best lens solution for many patients may not really be a good solution. So it has to be a tailor-made solution. A patient satisfaction will always be a moving target, and new lenses design will always be coming into the market. So remain a lifelong learner in order to stay at the top of your game. At the multifocal contact lenses, it's an option for people who wants transition from the bifocal to the multifocal glasses to the contact lenses. These type of contact lenses are great for people with active lifestyle who do not want to get chained to their glasses. So why presbyopic lenses? Because when you are wearing a glasses, you need to do a lot of head tilting to see the near. You'll have a restricted field of view. Of course, it's an outward symbol of aging. Switching glasses for reading, distortion optics of the progressive bifocals, weight of the spectacles, magnification, image jump, all these are complications of the progressive edition lenses. So if you need to have a better solution, you can go for a presbyopic contact lenses. So these are some of the consideration which we need to do when we are going in for a contact lens correction. So we need to check for the visual requirement. The occupational environment of the patient is very, very important. Binocularity and stereops is very important when you are planning for a monovision. The near ad required for the patient for their particular work is very important. Most important is the motivation of the patient to use contact lenses. Any medication if the patient is on is very important. The status of the tears and the tear film, lid tension position, sensitivity of the cornea is all the anatomical things that we need to look into. And of course, coming to the material as such, the contact lens material, availability of the lens in tint, and the cost involved is also a factor to be considered. Coming to the fitting strategies, always it is better to go for the disposable lenses. Have adequate number of disposable lenses to give a trial for the patient. And giving a trial has to be for a quite long time. It is not just the OP thing. You can't just give a trial for half an hour and check if the patient is comfortable. So extended trial with more realistic and better feedback would be the motivation for patient to use contact lenses. Use of trial lenses close to the power required is also very important. If the patient requires 1.5, if the trial given is 1, they may not be very comfortable. Follow manufacturer's fitting suggestions. Use tinted lenses to assess handling. Right, multifocal contact lenses comes as soft, gas permeable, and hybrid lenses. So hybrid would be preferable because they have the best of both worlds. So it will be more comfortable and gives the best results also. The options are either bifocal or multifocal. In bifocal, we have the alternating pattern or the concentric. Multifocal, we have the aspheric and concentric pattern. Basically, bifocal contact lenses have two portions of different power. The bifocal contact lenses are available in both RGB and hydrogen designs. Patients who have got a eyelid in normal position, average or smaller people, and motivated patients are favorable, else it is unfavorable. So basically it comes as a simultaneous or alternate image design. Simultaneous is that the light from the far, near, and intermediate enters the eye simultaneously. Essentially provides a far and near vision together, and it doesn't rely on the lens movement. So far and near correction zones are both positioned in front of the people in every direction of the case. That's the most important advantage. And the brain is allowed to select the image to either focus or ignore. So it's either concentric, aspheric, or diffractive designs. Concentric is the most commonly used, whether it is a bifocal or a multifocal lens. It shows a sharp demarcation between the distance and near power. It comes as either a center near or center distance depending on the occupation of the patient, and the zone size would be 3 to 4 mm. So since the zone size is fixed, the performance depends on the pupil size of the patient. Aspheric, it's a progressive addition type of lenses formed with alternation in the anterior or the posterior curvature. So use either the front or back surface aspheric design. If the back surface is aspheric, then the center would be the distance, and if the front is aspheric, then the center would be the near design. The power uniformly increases or decreases according to the type of. So it's not a true bifocal because what happens in an aspheric is it increases the depth of focus of the retina, it increases the depth of the field, thereby increasing the near range. It's an option for the modified monovision, especially when it comes for the severe presbyopes. So the advantage is that there is no ghosting because there is no ring involved in this. Clarity of vision is there for all the distance compared to the other models. It's a simplified fitting machine. It's something like a single vision lenses only, used mostly for the office workers. As I said, the disadvantage is again the pupil dependency. Diffractive lenses are made of concentric rings. Basically, they act like Fresnel prisms. Several zones of progressively increasing size are arranged concentrically, so they perform well in moderate presbyopes, offers higher resolution and sharper images. Pupil size doesn't matter a lot, so it gives a good quality, simultaneous vision, and is easy to fit. So the disadvantage is that it works well only in good illumination. When the illumination is not good, it doesn't work. There's a little bit of ghosting, and relatively smaller optic zone says that the fitting has to be perfectly well and centered. Alternating, as I said, this is a bifocal pattern, so it incorporates a reading or a near segment located eccentrically, that's inferior. It can even be added superiorly also. Need to look and alternate through the two separate portion to see either the near or the distance. It's not a simultaneous, that's why it's called an alternating. You can see either the near or the distance. The lens moves or the translates on the eye so that the vision alternates between distance and near. In the down case, the lower lid will lift the near segment up towards the pupil to see clearly. So fitting consideration, power of the near rod is important. Size and shape of the near segment is very important. Stability of the lens fit is very, very important. Right. So we'll skip on this. Contraindication, as I said, larger people, lower lid below or too far from the limbus, loose lids, poor blinkers, high riding lenses, poor motivation, low ad are all like contraindications. So advantage, definitely higher ad. This is going to work much better with a sharper near and far vision. Works well if it is very successful. And the disadvantage is it take a longer time to adapt because the patient need to get adapted to the use of lenses. The comfort is less because of the thicker designs. So some clinical examples, if the patient has got a smaller pupil, go for a simultaneous vision bifocals. If the patient has got a larger pupil, go for the translating design. So there are a few unsuccessful situations where the contact lens doesn't suit. One is a high myopes, the patient with a busy schedule, already having a dry eye, flatter corneas, laxity of the lower lid, and higher astigmatism. They are not going to be happy with the contact lenses. And whenever a patient with unhappy patient walks into you, just tell them that light is your friend, because most of these contact lenses work well if the illumination is good. In case if the illumination is low, they may not be very comfortable, but with that situation, never tell the patient to go for an alternate design or alternate procedure. And remember, the lenses works well together. Monocular doesn't work here. Whether it is a monovision lenses or is it a binocular lenses, doesn't matter, but make sure you tell the patient that it works only when it is together. And fitting multifocal is a process. It's not like any other one, glasses or something. You need to really spend a chat time with the patient both during and after the dispensing. If multifocal doesn't suit, we have other options which we are going to discuss later in the IC. And monovision, here the one eye is corrected for distance and the other eye for the near. It's not indicated when the patient has got an amblyopia or a reduced contrast stereopsis. And if there is a confusion or imbalance, vertical muscle imbalance, definitely it is not going to be a choice. So to conclude, I would like to give a small recommendation that if a patient is an emerging presbyope of 2 plus 1 diopter, simultaneous vision is the better choice. It gives full correction in both eyes. Maybe you can think of a mono vision if the patient is not comfortable. Mid presbyopes of 1.25 to 2, again simultaneous is good. Equally translating will be working for the well for the patient if given full correction to both eyes. Monovision, again, if that doesn't suit, you can think of a monovision. But for a late presbyopes of more than 2 diopters, always translating is going to be the best option, followed by monovision. So the correction of presbyopia is more about selecting the right lens and also the right patient that will provide acceptable vision at all ranges, both for the distant, near, and the intermediate. Thank you.
Thank you, Dr. Jayanthan, for the elaborate presentation. Just one question: are you saying all the multifocal contact lenses are pupil dependent? If so, you have actually illustrated that the center point is for near, and you're saying that light is our friend. So does that mean that when patient is going out in a bright light and seeing distance, should they wear some dark glasses to see more clearly for distance, or how does that work?
That's a nice question, because most of the contact lens wearers, they'll be more comfortable when they are actually indoors in a bright illumination. When they try to move out, see the illumination, we say that it is, when it is bright it works well, but it is contrast. When you go out in the sun, when you're trying to drive, definitely they are not going to be very happy. So in that, they need to really wear UV protected glasses. That's how the pupil stays at 3.5 mm, and you get both distance and near. When they're driving, when they want to look at the dashboard and see the readings, definitely the pupil has to be 3 to 3.5 mm. But indoors, definitely if the lights are bright, the pupil doesn't matter much actually. So it will be an optimum of 3 to 3.5 mm. Most of the multifocals work well. But only thing is, it takes time for the patient to get adjusted to it. Unlike the glasses, which you don't need a training or something. multifocal contact lenses, even the fitting process is late. You need to call the patient twice or thrice, give a time of 2 to 3 days for every trial, and once you're comfortable, then definitely you can go for it.
Exactly.
Because simultaneously they need to actually try to focus on one image and ignore the other image, so that they need to get trained. So the motivation is very important here.
Yeah, even we do give trials to them to use it for a couple of them. And about these aspheric, are there trials which are there for the aspheric contact lenses? Aspheric contact lenses which you had showed, which has an anterior and the
Posterior
posterior.
asperic, yeah.
So even for that,
Yeah,
trial lenses
it's
are
available.
available.
That was a wonderful talk, Dr. Jayanthan. Very elaborate and very clear. Gave us a lot of information. I just have few more things, if you can clarify for us. Do you have any specific brands? Because these are not very commonly used nowadays, but there is a lot of demand. Can you tell me some specific brands which?
I use Johnson and Johnson's.
Okay,
So that's one, because the reason is they give you adequate trial lenses.
that's
Whenever
one.
you ask for it, they'll give it to you, and they are open for replacements. And if you
Okay.
have a particular doubts or clarifications, they're ready to come down and then help you. There are a number of lenses available, but the problem is they'll just dispense. It's our headache to actually convince a patient. Here they have a technical person who can actually help you in fitting and the follow-ups also.
Okay.
So it works well most of the time for patients.
And sometimes they say monocular fitting will be better, binocular. What do you follow? Like in these fitting, you give the patient monocular or
To be very
binocular?
frank, it's always bilateral. That's always
Okay.
better. You can go for a monovision. But in case, even after repeated trials, if the patient is not working well binocularly, then we can think of a monocular. But to be very frank, if the patient is not comfortable binocularly, they will never be comfortable uniocularly. It's better to avoid uniocular corrections. And same with having a contact lens for distance and using a top of glasses is also not very comfortable. So it doesn't work that way. So there will be a lot of distortions for the patient. So it has to be either a multifocal lenses or you need to go for a progressive edition glasses. So combination of two doesn't work.
And till what astigmatism you prescribe? Because toric, there's
Uh,
not yet been launched, no?
Yeah, so toric is not launched, and toric definitely is not a good choice. If the patient has got an astigmatism, two, one, if it rotates, the vision is going to be
Yes.
very disturbing for the patient. So toric patients, we don't give a choice for them. It's a purely, my first choice would be a patient who requires, who are active lifestyle, who has got an active lifestyle, and myopes. Uh, Mild myopes or moderate myopes who needs glasses for reading, so they do well. And everybody who's between two diopters of hyperopia or myopia, they'll be happy. Higher myopes and hyper, they'll definitely be not be happy actually.
Sure. Thank you so
Thank
much.
you. Sir, I didn't get you actually. Okay, so -3 and -2. No, sir. No, sir. I have never tried. Maybe I have not tried, but generally, usually in that situation, I tell the patient to remove the glasses and read. They feel that more comfortable because whatever we said and done, unless the stereopsis is not there, sir. Yes, sir. So definitely. So in that situation, progressive edition lenses are the choices. Maybe now the progressive edition lenses has come up with so many designs. You can actually customize it. You can actually customize the design segment size also. So you can have an intermediate in the top, near
Yes.
followed. So you can customize it a lot. And the distortions, whatever we say, is actually lesser nowadays. So instead of trying all this for a banker who's got all three vision required to all three vision, it's better to sit with them, talk to the company, get a customized progressive edition lenses, and that works well, sir. Actually, and company is ready to do it. You can even shift the segment also. You can try to see. So Nikon is doing, Nikon is doing, Zeiss is doing. But only thing is, like when we have already have a good volume of regular progressives, they'll be helping out with this. So just for one lens or two lens, they may not be very friendly to us. That's a problem, sir.
Thank you so much, Dr.